Afternoon, Nina.
Hi, how are you?
I'm good. I'm good.
Good.
It was nice to see you at the Cultural Literacy Summit.
I know. I was so excited to actually see people face to face. It makes such a difference. I really enjoyed that conference, by the way. I really did.
Good. Good. Yeah, I thought it was well done.
Yeah. Looking forward to next year.
Yeah. I think that's something we can grow and build.
Mm-hmm. Agreed.
Yeah. We'll give it a few minutes here.
Okay. I was joking with my boss this morning because they got another 8 inches of snow up north in Layton. So some folks, didn't make it into the office. And I was saying that maybe for swag, we need to start ordering snorkels because everyone's so snowed under everywhere.
It was unbelievable. Yeah.
Oh, I know.
I can't believe it. We'll give it just another minute or so. Eric, you holding up?
Yeah, for now.
Good.
Just taking it one day at a time, my friend.
I thought, this I was going to have some time to catch up, and that didn't happen. It's today's been really busy. Just give it a second, and then all right, Eric, you think we're ready?
I don't know, has Jen joined yet? I think she's running this meeting, right?
No, she's not.
Oh, you are. Okay.
I'm running the first part of it. You may have to finish it.
Okay, great.
So,
let's do it.
So let's get started. Welcome, everyone. I'm Brent Kelsey. Jen called me about an hour ago and asked me to kick this meeting off. She is working on the PRISM Go Live project and is working with our pharmacy team on some issues right now. She may be joining the call, but she asked me to kick this off and send her apologies. So that's where she is. Why don't we quickly just do introductions? It's been a while since we've met, and so we'll start with you, Nina.
I'm Nina Farrell at Salt Lake Behavioral Health Hospital. I'm the Assistant Director of Business Development.
Great, thank you. Eric?
I'm Eric Grand. I'm one of the Assistant Division Directors with the Division of Integrated Healthcare.
Okay, Sharon.
Hi, I'm Sharon Steigerwalt with Medicaid. I support this work group meeting with several projects for the division. Thank you.
Great. Emma?
Hi, Emma Chacon, formerly with the state for a long time, now with Health Choice Utah. And the state's worst retiree is what I usually go by. So
Bonnie?
I'm Bonnie Alexander. I'm the revenue cycle manager for First Step House.
Great, thank you. Christine?
Hi, I'm Christine Jones, and I am compliance with Health Choice Utah.
Great. Jed?
Hi, I'm Jed Burton. I'm the clinical director at Weber Human Services.
All right, Jennifer Ford?
Let's see, got to grab the mic button. Hi, I'm Jen Ford. I'm the Director of Clinical Operations for Health Choice Utah.
All right, Greg? I think you're muted, Greg.
Yeah, the last piece, right, which is, all right, I'm Greg Trollen. I'm the office director for the Office of Managed Healthcare in Medicaid.
Great. Lynette? Okay, maybe she's left. Mark Greenwood?
Good afternoon, Mark Greenwood. I'm family medicine physician. I'm the chief medical officer for Molina Healthcare in Utah.
Great. Adam?
Adam Cohen, CEO of Odyssey House.
Great. Lynette, you're ready now? I see your hand go up. Maybe not. Jennifer Meyer-Smart.
Yes, hi, I am Jennifer Meyer-Smart, the Assistant Office Director for the Office of Managed Healthcare and Medicaid.
Great. Russ?
Thanks. Good afternoon. Russ Elbell with Medicaid and CHIP programs at Select Health.
Okay. Brian Monson? He may not be. Andrew?
Hi, everybody. Andrew Rigo with.
Great. Joseph?
Hi, I'm Joseph White with the Foundation for Family Life, Redwood Recovery, and the MentorWorks program.
Okay.
I'm the director. Thanks.
Brian Roach?
Hi there, Brian Roach, Assistant Director, Division of Integrated Healthcare.
Okay. Julie?
I'm Julie Ewing. I'm the Compliance Director for the University of Utah Health Plans.
Okay. Elizabeth? Looks like we lost Elizabeth for a minute. Patrick?
Yeah, Pat Fleming, Chair, Utah Substance Use and Mental Health Advisory Council.
Okay. Nelson?
Hi, Nelson Clayton, Behavioral Health Program Manager at University of Utah Health Plans.
Okay. And Elizabeth?
Sorry, I hit the wrong button. I hung up instead of unmute. Liz Kelch, I'm the Director for the Utah Substance Use and Mental Health Advisory Council.
Great. And then Rachel? We just saw that you joined.
Yeah, I'm with the Foundation for Family Life. I'm the executive assistant, and we are joining on behalf of Jim Dunnigan and invited us.
Great, great. Good to have you. Okay, so Sharon sent out a copy of our meeting minutes on December 9th. Has everyone had a chance to review those? Does anyone have any additions or corrections to the meeting minutes? Can I get a motion?
Yeah, Brent, motion to accept the minutes as presented.
Okay, we have a second?
I'll second. This is Russ Elbell.
All right. Anyone opposed to that motion? All right. We'll consider the meeting minutes approved. We, as I talked to Jen today, you know, we've been trying to keep these meetings going. I think our intent going forward is to schedule these meetings quarterly. And I hope that works for people. I know we have a tremendous amount going on, and so we're hoping that quarterly meetings, we can make them meaningful and that we can get the work done that we think we need to make. So that's our intent going forward, is to schedule this. Our next meeting will be in June. We have 2 issues on the agenda today, and Jen was actually listed for both of them, but as I said, she can't be with us. So Greg was going to handle the operational issues. Greg, are you ready to discuss the operational and provider issues?
Yeah, thanks, Brent.
Great.
And my information may be a little more limited than just all operational issues related to this, but let me dive into what's been happening. I know the HB 413 committee and the work group took kind of a hiatus as related to the fact that as part of those discussions that you were having related to coming up with recommendations about how to better provide services to the TAM population, a concern came up from providers specifically, and more specifically SUD providers, with concerns about the fact that there were claims and reimbursement issues that providers had with specifically the UMIC plans, which is Utah Medicaid Integrated Care. And with respect to that, it was the decision that the group of concerned providers would meet with the UMIC plans. And so we structured and have had several meetings over the course of the last several months, specifically talking about addressing cataloging issues related to claim submission and reimbursements, and have made significant progress, I think, and the group would agree that it's been very helpful for us to come together to talk, identify, and strategize around these particular issues. And again, part of this process was that if any recommendation that might include enrolling TAM members into our existing managed care delivery structure, those reimbursement concerns needed to be addressed, particularly since TAM are higher utilizers of SUD services, and to ensure continuity of care and access to care, we wanted to address those particular issues. So some of the key things that work group, I'll call it, engaged in was actually moving forward with or strengthening the individual meetings between the UMIC plans and specific providers. As you're aware, providers, reimbursement and claims issues can run the gamut, and it's not one size fits all. So there's been a lot of individualized work that has occurred to identify what the issues are, whether those are systems issues, coding issues, a variety of things, in order to identify fixes to claims submissions, and then as well as the reimbursement on those claims to providers. So there's been a lot of work there. There's been individual meetings that have been happening between the plans and specific providers. We've also just started to talk and identify more systemic policy-related issues that just impact providers as a whole. Some of those policy issues rest with the department, and so we've cataloged a variety of things that we need to just spend ongoing time and effort to resolve. And so in our process, we identified that really we wanted to deal with the immediate issues of unresolved claims or reimbursement issues. And so there was quite an effort, push towards getting those issues fixed, understanding that there's always going to be issues that come up. And so one of the other things that we did and were strategic about was just discussing what are key points of contacts with the plans when providers have issues, so that they can reach out directly and those issues can be resolved as quickly as possible. So that was one structural thing that we identified. And then the other thing was just as part of that, knowing what are the pathways to get these issues resolved when they arise in the future, because they will. And so just identifying how we get these things resolved. So I think it's been really helpful for the group as a whole working through these to come up with some longer term strategies. And again, the other thing we identified is that there were these immediate issues that we really needed resolution on, and the group as a whole, I think, is in consensus that there's been a lot of good work done there and that we've made good progress in that area. And then secondarily is just some of these longer term issues that we've identified that are going to take longer for us as a group to work through and to work on. And so we just wanted to just report back to this committee about the work that's been going on with providers and plans in resolving some of these more immediate issues, understanding that we have, again, other concerns and issues that we're going to have to just be focused on over the long haul and the long term. And again, we see this as just an evolving process. As other issues come up, we want to have a framework to be working through these. And so as part of just our structure, we will continue to be meeting with this work group to continue to work on these things. Yeah, so that's a high level overview about where we were. Again, I think the HB 413 committee or the work group kind of took a hiatus while we were managing through and discussing these claims and reimbursement issues. Again, I think the group as a whole would attest to the fact that there's been good work there. And so at this point, we're just providing this information for consideration to the HB 413 group as to how you guys might be moving forward with just the work that's on your plate. So any questions? Any other comments from folks who have been involved with this other working group with the UMIC plans and providers? Emma?
So I would agree. I think some good work has been done. There will always be some new issues that come up, right? As you know, the programs evolve. What does this mean for the original topic at hand? I mean, there's two things that, and I think that the work that has been done should continue. But now we're also going to quarterly meetings, and I'm asking the question just for the purpose of just for the group to know, because I have been one who has not been terribly anxious to just run to put the TAM population into managed care until we really felt okay about it. Both the plans felt okay about it, and the state felt okay about it, and our stakeholders and partners. So where do we go from here?
And who are you addressing the question to, Emma?
The state. I mean, I guess it's either probably to Eric and Brent, and I mean, there is the larger discussion that started this whole process. And I think, and hopefully the ACO folks will jump in, but I think the original hope for some of the plans was to, move TAM into the ACOs effective the beginning of fiscal year 24, which is not going to happen, right? Because, and I don't think it should happen right now. There's just too much going on. But have you guys talked internally about now what? State of Utah?
To be honest with you, Emma, we've had just very brief conversations on it. As you know, we're busy with a few other things right now.
Right now and stuff. I get it.
Yeah. So, and knowing and realizing that it wasn't going to happen for state fiscal year 2024, we've kind of tried to put it back in the back burner a little bit. And that's why we wanted to continue these meetings and do them quarterly, just so that we can keep you guys abreast of what's going on, where our thoughts are, and how it's progressing during the next year. I mean, as we get closer to developing the 2025 contracts, and whether or not that's probably the most appropriate time to have the discussion about actually moving TAM into managed care or not.
Yeah, and Eric, I think even that is just helpful to know that that's the kind of time frame we're working with.
Okay.
Sure.
Yeah. Joel, I see you have your hand up. Okay, Russ, I see your hands up.
Yeah, thanks, Brent. Hey, maybe building on Emma's comments. Well, first of all, completely agree, Greg. Things have gone well. I think some of our more recent discussions around policy on COB and as next steps and understanding that better at the policy level is going to be really helpful. Maybe, Greg, Eric, I know there's some reporting requirements, if I remember correctly, in the legislation around this work group for the department. When do you report back legislatively, and what goes into that report?
Yeah, I'm going to let Eric speak to that.
Just because. Honestly, Russ, I'm gonna have to get back to you on that. I really don't know.
So,
yeah, unless Brian knows. Great, go for it, Brian.
Well, I mean, yeah, not having memorized HB 413, I just pulled it up in the background just to remind ourselves. So the task of this working group is still to make a recommendation to the department, which we should be working towards. And that should include specific and measurable metrics. There's a list of 5 or 6 measures. And then it's only upon the department making the determination that we've met those metrics, the later of that date or July 1, 2023. So I think at this point we are all making the assumption the later date will be meeting the metrics after July 1, 2023. But then at that point, it would be implementing a delivery model change. So, but the main task for this working group is to make a recommendation to the department on metrics and ways to improve delivery of behavioral health and other things.
Right. Joel, did you have a question?
No, I don't know why my hand's up. I joined right when you said that. Sorry about that.
Okay. Greg, I see that your hand's up.
Yeah, I just wanted to append on what Brian was saying. So part of our goal was to just give an overview of this. The other thing we're doing is we're going to have a summary write-up about the work that the UMIC and the providers have been engaged in related to claims and reimbursement, as well as the other things that we've identified. And then we'll furnish that back to the committee just as a piece of what it is you guys have been working on, as well as considering with respect to making recommendations about delivery of services for TAM. So.
Okay, great. That is the question, though. I think I think we all agreed that we needed to work through these provider issues, and now we've got to get back to the business at hand. So I think that's the intent in future meetings is to discuss these issues in more detail. We had one other item on the agenda today, and Brian, you were going to discuss housing-related support services.
Yeah, thank you. I can transition to my presentation, share, and I can take over presenting if you would.
Okay.
All right, thank you. So again, my name is Brian Roach with the DHHS Assistant Division Director here. I'm presenting today about a program we're pretty excited about, and it is relevant to this work group. This was first applied for back in 2019 as an 1115 waiver, and we got authorization last year. As I think everyone knows, we in Medicaid love acronyms, so here's another one for you. Housing Related Services and Supports, HRSS. So for the rest of this presentation, I'll be referring to it as HRSS. So HRSS program is part of the 1115 demonstration. 1115 waiver began about 2 decades ago. It was our first way of creating the PCN program, and it's evolved to add a lot of flexibilities to create unique programs, and this is one of them. So the HRSS program specifically serves targeted adult members, Medicaid members or TAM members, those that are experiencing homelessness, food insecurity, transportation insecurity, as well as interpersonal violence and or trauma. We'll later on in this presentation, we'll talk about some of the needs-based criteria and risk factors that would make someone eligible for this program. So the first of 3 services offered by HRSS is tenancy support services. These services aim to help clients maintain successful tenancy by offering housing assessments, individualized support plans, and assistance with various housing-related processes. Clients receive education and training on tenant and landlord rights, eviction reduction services, and assistance with housing voucher subsidies. This is structured in kind of a graduated authorization, so recognizing that individuals require more help up front, so 10 hours per month in the first month, then 8 hours, then 6 hours per month in the third month and afterward. The second of 3 services we offer is community transition services. As you can see at the top, we offer up to 2 authorized episodes per person for 5 years. And each occurrence, we allow up to $2,000 worth of expenditures. These services provide some of the valuable services necessary to live a safe and healthy life. As many of you know, it's not enough to have a roof. A lot of times, having a stable environment includes furniture, food preparation items, pots and pans, pest elimination, moving expenses, home accessibility adaptations, including wheelchair ramps, something like that. These are all intended to help create a safe, stable, and comfortable living environment for members. And third service we offer under this waiver is supported living services. These are coordinated services that focus on mental health, substance abuse, and independent living supports, aiming to address ongoing needs and challenges to maintain the long-term stability of clients. So next I'll transition to more of the operational side of how things get authorized, what goes into that authorization. So the care plan and tenant housing services contract outlines the services to be provided. This is agreed upon with the service provider and the member. They develop that contract as well as going over the participant rights and responsibilities. Both of these documents are emailed to this website on screen, LTSS Housing. This is our shop, so we approve these documents and it authorized services to be reimbursed. And we do have a quality improvement component. We monitor for effectiveness of the program, assurances by service providers guaranteeing health and welfare of participants. And this is an ongoing monitoring requirement, as well as the fact that this is an 1115 waiver, and part of every 1115 waiver is an evaluation plan by an independent evaluator. And we are going through the design of that evaluation plan, and at a later meeting, we're happy to present some of the findings of that evaluation plan. Yeah. All right, and as far as the process for getting clients authorized for this, so agencies can connect with our HRSS team for support, guidance, training, on implementing this program. We established an ongoing dialogue with our staff and service providers, give them training on how to complete care plans, the tenant housing service contract, how to become a Medicaid provider, and the billing process. It's not just a one-time setup and a good luck. We do offer some ongoing dialogue and training. Some more details about the program. We do have a specific provider manual for HRSS, a lot more detail in that about more service criteria and what's encompassed by it and the needs-based criteria. Some examples of needs-based criteria are, oops, I jumped. Excuse me. A diagnosable substance use disorder or serious mental illness, someone that requires one or more activities of daily living or ADL. A risk factor could be living or residing in a place not meant for human habitation or currently living in supportive housing. These are supportive factors, and each individual has to meet at least one of the needs-based criteria and one risk factor in order to be found eligible for the program. And as well, so the middle bullet point there, a reminder about TAM eligibility. It's determined through our DWS partners. And this slideshow is primarily designed for agencies. So we would invite agencies to contact DWS, but anyone on this phone call, feel free to reach out to us if they have questions about TAM eligibility. So here's some key data points for the HRSS program so far. So it was approved, like I mentioned, last year in summertime of 2022. We began enrolling our service providers in fall of 2022. And then we started accepting our first applications in December 2022. And at this point, we've paid claims. We have some individuals, I think, on the next slide. Yeah, so at the bottom of the slide, 81 individuals are currently being served, and we have 18 applications pending. So we'll hit that 100 mark pretty soon. Pretty excited about that, and hopefully we continue to grow with the need that's out there. At the top, these are the providers that we've already contracted with, and we welcome others that are qualified and able to serve in this area. On the next slide, let me back up just a little bit. This website, again, is the go-to source for any interested providers wishing to reach out to us. And with that, I will close. These two names, that's not myself, but these are our two excellent employees in the housing area. So Chris Wynn is our housing coordinator, and Linda Robinson is the HRSS program manager. Very responsive to needs that are out there. And with that, I'll take any questions. Sean.
Actually, just a comment, Brian, especially with other members of leadership from DHHS here. Christine and Linda, I think, have done an incredible job rolling this out and just being a collaborative partner with us as providers to make sure that we're maximizing the utility of these new codes for the people we serve. So good job to them and good job to you guys for supporting them.
Thank you, Sean. I will pass on that thank you to them as well.
Brian, can you share, like maybe put this out to this group, your slides? I think they're very helpful.
Yeah, absolutely, I will.
Thank you.
And thank you for the comment in the chat, Jed. Russ, if you'd like to go ahead.
Yeah, thanks. Thanks for presenting this, Brian. I'm just curious if there's been any discussions about extending this type of work beyond TAM. we do see individuals who aren't in TAM who have housing needs. We see that quite often. We also see individuals who have housing needs who aren't in TAM who later transition to TAM. So it's it's a complicated environment out there. Just kind of curious if there's been discussions about that.
Where there have been limited discussions about it, I think the discussion also, a part of the discussion has to be how much funds are available in the expansion fund, which has kind of been subject to some debate at the Social Services Appropriations Subcommittee. So it is a good point, Russ. We do recognize that some individuals beyond TAM may be in need, but that's going to be an ongoing conversation of whether there are enough expansion funds available to serve those individuals or whether we would need an additional appropriation for that.
If there were additional funds, does the state have to then amend and get approval for the 1115 waiver?
Yes, we would. So our current approval just does cover these TAM numbers. I am not sure whether we could extend it just with a technical amendment or it may require a formal amendment. And Emma, I see you're thinking a formal amendment.
I would think a formal amendment because the criteria was very specific. That basically meets the criteria for very closely meets the criteria for eligibility for TAM. And so if we were going to go beyond that, I think because it will affect budget neutrality. And in the past, they've always said if it impacts budget neutrality, it has to be a formal amendment.
Yeah, that is a good point. So, sorry, Joseph, before I go to you, I just want to address the comment by Lisa in the chat. And this has been brought up before about women getting legal custody and moving to the parent caretaker relative program, or becoming pregnant is another example. We're aware of that and have started discussions with CMS about that, about our current benefit category hierarchy does not allow us to keep individuals in TAM if they do become a parent or become pregnant. So we are in discussions about changing that, but it would require some programming on our side. Joseph, I think you are next.
Thanks, Brian. So yeah, Representative Dunnigan told us about this. We're so excited, and it's going to be a great service and support for a lot of folks. We serve TAM clients now, so we just wanted to know what's the process for enrolling or applying for it.
Yeah, so I'd be more than happy to connect you with our HRSS staff. And Joseph, can you remind me what agency you're with?
Foundation for Family Life and Redwood Recovery is our treatment program. So.
Great.
Thank you.
I will have them reach out to you.
Wonderful. Thank you very much.
Yeah, thank you. Pat?
Hey, Brian. Yeah, Brian, Pat Fleming. Hey, not related to the support program we're talking about now, but the whole issue about enrollment in TAM, the application process, DWS. I still keep hearing things out there that is still very difficult to get folks enrolled in Medicaid and TAM specifically through DWS. Are you guys hearing anything, or do you have any kind of ongoing? I mean, since we years and years ago we split this up took it away from Medicaid and gave it to DWS back before I think you were born, Brian. But anyway, it's always been a question. And I'm just wondering if there's been if your department has any formal way of getting any information about if there are any snafus in the enrollment process, or TAM is run by DWS.
So to be honest, I'm not aware of specific snafus to that. I mean, we do have daily and weekly conversations with DWS about improving enrollment process as a whole, but those have not focused on TAM recently. But with that, I can ask the question, see if there's a specific delay or like a higher denial rate or something like that that we should look into. All right, let me look at I don't remember who. So Sean.
Yeah, thanks, Brian. I want to address two things. One is this is just me personally. I've kind of looked at the HRSS services being limited to TAM as being sort of a pilot, so to speak. And ideally we would be able to demonstrate cost savings to the healthcare system because we're reducing the number of rehospitalizations or returns to treatment. We're seeing improvements in management of chronic health conditions, that sort of stuff, which would then provide some rationale for us to expand to some of the other Medicaid plans. So that's sort of been my thought about it, but let's be deliberate. Let's show that what we think will improve or create cost savings does in fact create cost savings. The other one is more to Pat's point about difficulty with enrollment. I've heard it a little bit differently from homeless service providers. So folks like the Road Home or 4th Street Clinic, that TAM isn't their preference for enrollment. It's their preference to get individuals enrolled in the more traditional Medicaid plans because those are indefinite. And they see the 12-month limitation as being problematic for the people that they serve. What I've tried to share with many of the folks from that segment of our system is that, but TAM, for individuals who are qualified, TAM buys us 12 months of healthcare. So let's get them enrolled in a Medicaid product so that we can buy 12 months of healthcare, and then let's work on getting them into some of the other plans that they might qualify for.
So sorry to jump the queue, but John brought 4th Street Clinic up. So I wanted to clarify. It's not really about the challenge with TAM really has to do around the criteria related to individuals who are experiencing homelessness and that chronic homelessness definition. And that is the real limitation from a homeless service provider standpoint, in making sure that we have that documentation that the individual has that chronic homeless status and the disability. That is the real limiting factor to enrolling an individual in to TAM. And so oftentimes other Medicaid pathways are a little bit more straightforward for us because we don't have to do all of that other additional work.
That is a good point.
Thank you, Janita.
So catching up on some of the comments, Joseph asked the question about will clients who are no longer on TAM but who are on adult expansion Medicaid still qualify for HRSS? The answer is no right now. It is just a TAM only benefit. Joseph, did you have any other question around that?
No, that's great. Thank you. That's all I need to know.
Thank you. Emma, I think you were next.
Yeah, I was just going to add, Brian, because I think this predates your involvement, but for folks who were involved at the beginning of TAM, the DWS process was very different, right? We identified specific providers in the community who had basically authority to submit documentation to a special, I think it was an email for TAM applications. And somewhere down the road, not too long actually before I left the state, DWS decided they no longer wanted to do that because they were feeling that was getting unwieldy, and they were going to just put TAM applications into their regular queue. And my understanding is that they made some commitments that, you know, TAM would not get lost in that queue. But given the, you know, number of applicants and all of the other chaos that's going on with, you know, the unwinding and everything else, I think it's probably a good idea to review that with them to make sure that TAM folks are not getting lost in that queue. Because if they're not being responsive, I mean, there was a lot of provider hand-holding of those applicants initially, and if that's not going on now, that may be part of the problem.
Yeah, so it is a good point, and I think this may be a good topic for next meeting. We can review that eligibility process for TAM. Russ, I think you were next.
Yeah, thanks, Brian. And I really appreciate the discussion, some of the comments around some of the the challenges of people moving back and forth. And I know that wasn't necessarily the intention of your presentation, but I do think it would be helpful to get some visibility on how often that happens. I wonder, could the department actually run data to see how often transitions are taking place between a regular Medicaid program into TAM, and also from TAM back into a regular Medicaid program, so we could understand maybe the extent of the challenge of people needing a benefit like this and or losing a benefit like this because of transitions.
Yeah, that is a good point. I know we have pulled that data in the past. I do not remember it off the top of my head, so that is something that we should be able to provide.
Thank you.
Andrew.
Brian, following up on Russ's comment and one prior to that, I know that we have had we've talked about wanting to have a conversation about how we can possibly if there are ways that we can find to make sure that TAM folks definitely and hopefully other folks as well can have access to the HRSS services beyond their eligibility for TAM itself.
Yeah, so can I get a little clarification, Andrew? So beyond, so this isn't, I guess in my mind, I'm thinking of two different things. So if within the 12-month certification period, they become a parent or pregnant, today that transitions them off TAM. But if that doesn't happen, they just get a job, let's say, a part-time job, they move to adult expansion because of their income change. You're saying adding the service to adult expansion as well to broaden it beyond TAM.
Yes, through mechanisms like in lieu of services or
right.
something else if it's something else if it turns out to be available and a better option.
Good point. Okay. Pat?
Yeah, thanks, Brian. Hey, I just want to kind of punctuate this thing with John Needy's comment and Emma's. I really think it's important to get somebody from DWS at the next meeting and maybe future meetings of this group. I do think that TAM is not getting. I think there are a lot of barriers being thrown up that don't. And I think if we can work with them to have them understand, like what the point Janet had made about having to verify their homeless status. If it's too difficult, there's got to be a way to make that simpler, and it shouldn't be a bureaucratic process. And I just want to make sure that we follow up and get a person at an appropriate level inside of DWS, somebody who's got some authority to get on this call so we can hash these things out.
Yeah, it is a good point, Pat. And I think maybe Johnny, that's a good thing. We could connect with you beforehand to better understand and be prepared for our next meeting.
Yeah, we'd be happy to chat.
Okay, thank you. And Joseph, I think I see your hand up, but that was probably from prior comments. Is that correct? Oops, yeah, probably pressed the wrong button there. Okay. Well, thank you. That was a good discussion. A lot of eligibility discussion in the process. So we'll come prepared next time to dig into the eligibility for TAM and the movement to and from TAM. With that said, so Brent mentioned in the chat before he had to leave that he had a prior commitment he had to leave at 2. So I will just be in charge of closing out the remainder of the agenda. If there's any other questions, I'm happy to take them at this time.
Hello? Hello?
Oh, hi, Representative.
On my phone anyway, sorry. So I caught the last half hour, just a couple of comments. So this last session, I did talk with Jen. Is Jen on is she in this meeting?
She was unable to join us.
Okay. At any rate, I worked with Jen, and I actually had a request for an appropriation to expand this program to the full expansion population. Now, it sounds like we would have had to address a waiver or whatever, according to Emma. But I did have a request in there that would have expanded this to the entire expansion population, not just the TAM piece of it. And I put it in one of the major housing bills. It passed the House, and the Senate took it out. And even though I fought for it at the end, it did not remain in. So that's just for information. I have heard concerns about TAM enrollment not going smoothly. I talked to DWS, it's probably 3 months ago now. As Emma alluded to early on, she and I and Nate and others, as I recall, had a meeting with DWS to try to facilitate a smooth TAM enrollment process. I do think that we have lost that. Although when I talked to DWS, they said no, the person that we tasked that with is gone. But we have this program, we have this link that you can go on. But I'm glad to help follow up with that. I think we need to work on that. I'd have a question as far as eligibility for TAM and seeing if they qualify for homeless. There are other doors to get into TAM, isn't that correct, other than just chronic homelessness?
That is correct. Yeah, justice involved and individuals requiring behavioral health treatment.
So
right.
The discussion that I heard was mainly on, it's a problem because we can't verify if they're chronically homeless. Is that the biggest population or applicants? Or it seems like there's a lot that are coming out from recent incarceration that would be eligible for TAM and don't have to worry about showing. I mean, they could qualify under those other doors.
You're correct. They could qualify under those other doors. So even though one of the 3 categories of TAM is that chronically homeless population, that's not the only one that would qualify for HRSS.
And then the Arizona, and we're having a meeting on this in about 3 weeks with Jen and myself and maybe some of you. Arizona is telling us that they've gotten approval for this housing support program for more than just the first and last month's deposit. And it doesn't sound like it's just for TAM because they don't have TAM. And so I'm interested in exploring how we broaden that. And I guess those are just some thoughts, and I'll be quiet.
No, it's very relevant. And I'm curious whether that's through the ILOS authority or something else, but we can certainly research more on the Arizona authority.
And you may want Oh, I'm sorry. I was going to say you may want to check California as well because they are, I believe, are submitting a request to be able to pay rent for up to 6 months.
Yeah, that's just what I was going to say, Emma.
Yeah.
We did see that, and yeah,
Is
as
that
far as
recent?
I know, I think, yeah, I think I saw it within the last month, but as far as I know, it's just a request so far.
It's
No,
just a
no,
request.
yeah,
Yeah. It has not been approved yet that I'm aware of. So.
right. Okay. Good topics. All right. Well, yeah. Thank you, Representative Dunnigan. Nina?
Is there any time frame that you can provide in terms of how long it takes to process these applications and being able to provide the fundings for housing?
Not offhand. We do. I mean, I think the biggest delay from the beginning was just getting providers enrolled. Now that providers are enrolled, it's a pretty quick process, but I don't have specific time frames. I can get that for you.
I'd appreciate that because being an acute psych hospital, obviously we have sometimes folks that are in a real time crunch and have a time frame urgency to get shelter. And so I'd be interested in anything you could provide us with that information.
Yeah, good point. All right. Well, thank you for the discussion.
Maybe one other quick comment. May I make one other quick comment? So there was some discussion on if we broaden this, is there money? You know, I think you mentioned it, but in my proposal during the session was to pull $3.9 million out of the expansion fund. There's money there, as you know, and this actually, I think, is a justifiable reason to use that. This is for the expansion population. And as I understand it, this waiver came out of the original expansion bill, Senate Bill 86. So I think it's a natural fit. But this session, if anything had Medicaid in it, you know, it just got whacked, or at least many of them did. And so I think this is an appropriate use of the expansion fund. And we'll just have to follow up and see what we need to do so I can work on it next session to either get a waiver, plan amendment, modification of our waiver, so we can take this broader than the TAM population. Thanks.
Yeah, thanks for that comment, Representative. Yeah, you would be better able to speak to that than me, so I appreciate it. All right. Well, with that, thanks again for the discussion and for your time. So, as previously mentioned, this is now a quarterly format. So we will wait until next meeting. Can I have one final motion?
Motion to adjourn, Brian.
Thank you, Pat. With that, wish you a happy weekend. Thank you.
Thanks. Good meeting.
Thank you.
Thanks, everybody.
Thank you.
Bye, everyone.